Good afternoon and welcome to all of you. I'm Anna, I'm Therapy Development Specialist for FEops, and I'm happy to welcome you in this educational session organized by FEops at London Valves 2021. The education objective of this session today will be mostly a case-based learning discussion on a clinical case, in order to be as close as possible with your clinical interest, your clinical reality. And we also want to ensure interactivity. This is why we will submit you a couple of polls. In this way, we will ask your opinion about a topic, and we can discuss this opinion with our faculty. The 30-minute session today will be focused on FEops HEARTguide as novel pre-operative planning tool in LAAo closure intervention, in particular using the Abbott Amplatzer Amulet device. Now it's my pleasure to introduce you our faculty, Dr. Cruz from University Hospital of Salamanca in Spain, and he will share with you his clinical experience in using FEops HEARTguide together with the Amulet device. Now I will give the floor to the faculty. And I wish you a very good session.
Okay. Can you see my slides? Okay. Great. Good afternoon. It's my pleasure to be here, and I would like to thank FEops and the organizing committee, the kind invitation to participate in this session. In the next few minutes, I'm going to discuss the impact of computational modeling simulation software with FEops in LAAo occlusion with the Amulet device. These are my disclosures. As you know, right now, LAAo occlusion is a procedure with a very high success rate. In recent registry, the success rate is around 99%, and with a very low rate of complication. Again, in this registry, the rate of severe complication is less than 1%. But anyway, I really feel that there's still room for improvement because, for example, as you can see here in the slide, in the Amplatzer Amulet multicenter registry, there were at least 6% of the patients that needs more than one device per procedure. In the recently published Amulet IDE trial, complete closure with the Amulet was 63%, and it was lower for Watchman. It's the old version of the Watchman. It was 46.1%. And also it has been described that device-related thrombus could be in some occasions So I really feel that we need new tools to make this procedure safer, easier, more precise, and potentially this could improve our long-term results. So here's our first poll question. So as you can see, our first question is, do you see a need to access to novel pre-operative planning tool as FEops HEARTguide? And you can pick no, I'm fully satisfied with standard pre-operative tools. B, I'm willing to discover new solutions to optimize my pre-operative planning. And third, actual solutions are incomplete for the optimal hearting decision. So let's see your answer. So Anna, if we can see the answer of the audience. Okay, so it seems that most of you still think that we need new solutions and the actual solutions are incomplete. So that's good because it's exactly what I really think about this. So we need new tools, and FEops is a computational modeling simulation software. So with this software, what you can get is evaluate the device size, selection, and positioning of the device. Also, it can potentially reduce procedural complications and increase therapy efficiency. It's great to train centers that are at the initial steps of their learning curve, and also, of course, it can support device R&D. It has been used for the last few years, especially in Europe, and it has been already validated, as you can see in this paper. And also is ongoing the PREDICT LAA study that will determine the final position of this type of technology in LAA occlusion. So let's see how it works. You upload a CT on the system of FEops, and then you get this. The first thing you get is the anatomical measurements. As you can see here, you can get an idea of the shape of the appendage, also the morphology, and you can get all the measurements that you need. So you can get the landing zone here on the slide on black, and also you can get the blue, that is the osteum. So you get minimum diameter, maximum diameter, perimeter, and area. And based on these measurements, they recommend you to use different devices. The second step is that the FEops give you the virtual implantation, assessing different size and different positions. For example, here you can see in the upper part, if you use an Amulet 22 in distal position and proximal position, and on the lower part of the slide, you can see an Amulet 25 in a proximal or distal position. So you get an idea, you are able to predict which is going to be the final position of the device, and also what is even more important, FEops can predict sealing. As you can see here with a color scale, it's able to show you the compression of the device, the apposition of the device, and also the apposition of the disc. And finally, also predicts frame deformation. So here you can see the virtual implant on the left, and on the right, you can see the final result on angio. So now let's see some cases. The first case I want to show you is a straightforward case. So again, just to repeat how this works, you can log on the FEops web page, and then you upload the CT. So 2 days later, you get all the measurements that you need. So again, here you can see the 3D measurements from the DICOM CT. So you can get the osteum, again, minimum, maximum diameter, area, and perimeter, and also the landing zone. In this specific case, as you can see, it was quite oval, especially the landing zone, because the minimum diameter was 16.3 and the maximum diameter was 21.6. So if you are planning to use an Amulet device, this is the sizing chart. You can see that with a minimum diameter of 16, you can use a 22, but with a maximum diameter of 21.6, you can use a 25. So the FEops give you the simulation of the 22, proximal or distal. As you can see here, you can check the compression of the lobe, the compression on the disc, and also you can predict the sealing. And this is the same simulation, but with the 25. So you can see my previous slide and this slide. In this case, we decide to go for a 25 millimeters Amulet device and try to implant it proximal, because we feel, as you can see here, that it was the best position to get a perfect result in terms of occlusion. Also here, you can see how you can play and decide which is going to be your best working projection. This is with the 22, and you can see here the 25 proximal. That was our final decision, and it's quite easy to see the position of the device, the frame deformation, and all the information that you need. So as I said, we decided to go for the 25 implanted proximal, and this is the case itself. So you can see here exactly the same morphology as the FEops and the CT predict. So it's like a cauliflower, but most of the lobes are distal. So that was the caudal and the cranial projection. Here we go with the 25 millimeters Amulet device. You can see that we try to implant it proximal. You can see on the left how close was to the osteum. Here is the deployment of the disc, the tag test. And you can see here the final result on angio. You can compare what it was simulated, but FEops, so it was exactly the same, and a very nice result without any kind of leak on echo. The second case is quite similar, but in this case it's a larger device what we need, because the minimum diameter provided by FEops was 25.7 and the maximum diameter was 26.6. Also, there was some pecten muscles at the level of the landing zone. So with this diameter, you can decide what you are going to use. You can use a 28 proximal, 28 distal, 31 distal, or 31 proximal. In this case, as you can see, we decide to go for a 31 distal because we really feel, as you can see in the slide, that it was the one that provides more a position of the device in terms of lobe, in terms of this, with enough compression and with complete sealing. So this is the case. You can see the injection in the cranial projection. You can see our injection in the caudal projection. How we deploy the 31 millimeter distal, we will try to be a little bit deeper than in the previous case. The deployment of the disc, and again, you can see perfect result with complete sealing. And again, here you can see on echo, no flow at all. You can see the final injection on angio and what the FEops predicted. So you can see that it was exactly the same. It's amazing how you can predict the frame deformation, and it was exactly the same as it was predicted. The third case I want to share with you, you can see that the morphology is different, but this is also quite round, it's not oval. So in terms of landing zone, the minimum diameter was 18 by 21 in the maximum diameter. So for this, the sizing chart of the company recommend a 22 or a 25. So you can see in the upper part of the slide, 22 proximal, 22 distal, and again 25 distal and proximal. And just based on FEops, we decide to go for the 25 proximal. You can see here our injection. So somehow it's a chicken wing, so it's a proximal bend, but there's enough space to deploy our device just at the level of the landing zone without performing sandwich technique. So here you can see how we deploy the 25. So it was in a good position, and we deploy the disc, as you can see here again, complete covering of the osteon, enough compression of the device. And again, you can see on the left, the final result on angio and the prediction with the FEops that you see that is exactly the same. Furthermore, with FEops, we are able also to decide which is going to be the best transeptal puncture site. This is quite useful, especially if you are planning to use the Amplatzer steerable sheath. If you are not familiar with this, I will just make a few comments on the steerable sheath. So this is the new sheath for the Amulet device. It's steerable, it has a hemostatic valve, and also it's a one-to-one torque. So you can see here how just making a counterclockwise rotation on the handle, you can get a deflection up to 0 degrees. And if you perform a clockwise rotation, you can go up to 120. These are the difference between the fixed curved sheath and the new one, the steerable sheath. The overall length of this sheath is a little bit longer and it's a little bit larger in terms of sizing. So it's 14 French, but all the other things are the same. So I will share with you some examples what you can do with this new steerable sheath. So this sheath was launched initially in Canada and 15 on June in 5 centers in Europe. So the experience is not so large so far, but what you can do with this especially is just to be more coaxial. As I said at the very beginning of my talk, I really feel that we need to make this procedure easier, safer, and more precise, because if we are able to be more precise, our results are going to be better. I really feel that we can improve our complete closure rate. So here, as you can see, on the left, this is our initial approach with the sheath, but once we have the ball, we are able to modify the coaxiality of the sheath to make a perfect implantation. So let's see one case with the steerable sheath. You can see here again how we are able to decide with FEops which is going to be the best transeptal puncture. As you know, in most of the cases, we recommend to perform inferior and posterior puncture in order to be more coaxial to the neck of the appendage. And also here we are trying different devices. So this is the 18 amulet device implanted distal, and it seems to be okay. The other possibility was the 20 implanted distal. So as you can see here, even with an inferior and posterior puncture, that is the black line, we have an extra bend just at the level of the neck of the appendage. So with FEops, we were able to anticipate that it should be quite difficult to be coaxial. So this is an inferior and posterior puncture. This is our first deployment. It seems to be okay, to be honest. But in echo, we were able to see that the position was not good. As you will see now here, so you can see that there's half of the device that is out of the appendage. So just making this recapture and modifying the position of the seat with the deflection, you see how we change the position of the device and we perform a new implantation. So the first one is on the left, red arrow, the new one is green. And here in this position, you can see in echo that our result was much better. And finally, we deploy the disc. So this is the final position with a very nice result, as you can see on echo, complete sealing, even we were not coaxial initially. So this is the result, as you can see here, with complete apposition of the disc at the level of the ostium. We have already published this case because I feel that it was the first one that showed the benefits of using FEops in order to use the Amplatzer steerable delivery sheath. The second case I want to share you, and this is going to be the last one. This is a more complex anatomy because it's a small appendage and also it's chicken wing. So we try different devices, as you can see there. You need to decide which one we were going to use. So we decided to go with a 18 distal just to make somehow a sandwich technique. That one is the one that we decide finally. And also here you can see that there was, if we perform an inferior and posterior puncture, we can be really coaxial to the neck, but if you want to perform sandwich techniques, somehow you need to begin the deployment in the wing of the chicken wing anatomy. So this is how we advance the delivery sheath, the Amplatzer steerable sheath. This is our injections. So you can see chicken wing, very small appendage. And we began the deployment with the ball. And in this position with the ball, we make a contrast injection, and you can see that we are coaxial to the neck, but we are not coaxial if we want to begin the deployment on the wing of this anatomy. So you see how just making the deflection of the seat, we can modify the position of the lobe. And just in this position, we began the deployment. So the distal part of the lobe was just deployed at the level of the wing. So we were able to make a perfect implantation, as you will see here. Just with the distal part at the level of the wing and the rest of the lobe with enough compression. And here you can see our contrast injection just in a perfect position. And now we deploy the disc. As you will see here. And we achieve again complete closure. This is the tag test, and this is the final result. Again, you can see on the left the final result on angio, and on the right what it was predicted by FEops. So after this presentation and after these cases, we want to share a new poll question. So after this case report, how do you perceive benefits of using FEops HEARTguide into your practice? The first option is no additional benefits. The second one, some benefits to increase the confidence in the decision for sizing and positioning. And the third one is real innovation in pre-op planning to predict potential complications. So you can share, you can send your answers, and let's see the results. Anna, can we see the results of the poll? Okay, so I'm quite happy because it seems that my talk you believe in what I have said, and I really feel that we need real innovation, as you will have seen with FEops. So just based on this, my conclusions are that new tools can get better results. FEops has been validated for frame deformation and leak assessment with physicians and real cases. And FEops right now is unique, showing real interaction between anatomy and devices which demand special development and skills to be performed. And what I really feel that is going to make a big difference with FEops is that the next step is to develop a DICOM solution where the physician will be able to interact with the platform. And that will be a big step, I think, for this software. So thank you for your attention. And now feel free to ask me any question with the chat.
Yeah, thank you. And I have already some question for you from the audience.
Okay.
And one question is about how easy is to integrate FEops HEARTguide in your daily practice. So about timing, about how to organize your clinical routine to integrate FEops.
To be honest, it's quite easy because in 24 hours you can get your results. You just need to upload on the system that is really fast your CT using just DICOM CT, and you can get the results the day after. So, I mean, it's not a big deal. And when you have that information, you have everything you need. And also as I have shown in my presentation, you can play with it. You can change the device that you want to implant. Also, you can say, okay, I want this more proximal, more distal. And I really feel that you can get all the information that you need. And also, and that is not just FEops, it's just how we work. I really feel that now all the patients should have CT before the procedure, so you will have that data. And probably in the next few years, most of the centers are going to change to use micro TE probe, or ICE. That is what we are doing in our center. So for that, in order to use this minimalistic approach, you need to have all the information pre-op. So I really feel that this type of software can help you in pre-op. And after that, you have all this information, you can change to minimalistic approach with ICE or mini TE probe. So this is finally good for the patient.
Thanks. And the other question is a sort of comparison between FEops HEARTguide as a preoperative planning tool and other tools available on the market, for example, Trimension.
Yeah, so I mean, with other softwares, what you can get are the measurements, but what is unique with FEops is that it's able to predict frame deformation and can help you to decide which is the best device to get better sealing. So that is a big difference because it's not just measurements of 3D reconstruction. It's 3D reconstruction measurements, which is the best transeptal puncture site. And also you can get that extra information on sealing and frame deformation.
Okay, I'm checking and there are no more questions. So in conclusion, first of all, dear Dr. Cruz, thanks a lot for this interesting session and for all the explanation you were providing us. And thanks also to the audience for participating. And I would like to suggest you also to visit our website for additional information and also to test the platform. And so thanks again to everybody. And I wish you a good London Valves 2021. Thank you.
Thank you, Anna. Thank you, all of you.
Thanks.